All right, so today is Tuesday, November 10th, 2020. We're going to be covering the ankle and the foot. I've uploaded the notes to the Canvas site. I will probably be adding to those, and if I am able to write these things up pretty soon, I will type them up and just email them directly to you, so you won't be confused. All right, so obviously the ankle plays a very, very, very important role. The ankle and the feet give us stability, grounding, flexibility, physically, emotionally, psychologically. They support our entire body weight. It's really fascinating to me that our ankles are pretty small relative to the rest of our body. The only thing is, like, our wrists are pretty small. Anybody that either has participated in athletics or watches athletics, particularly contact sports like football or football soccer, or rugby, or what else? Or even, it's not a contact sport, but basketball, things like basketball. Or you look at horses, equestrian sports. They've got, MMA. Yes, thank you. That was the one I was trying to think of. Thank you, John. The ankles take a real beating, and they are, of course, the predominant injury in the United States. I don't know about the world. I haven't done any international research, but supposedly about 85% of all musculoskeletal injuries in the United States involve the ankle. So, and it's no coincidence, right? So on a psychological level, we look at how we experience support, how we receive support from others, even maybe how we give support, our beliefs. So if you think about it, the bones are said to represent our deepest beliefs, our core beliefs. And the ligaments obviously hold bone to bone together. So, what are the beliefs that what would you say, extend beyond from like one area of our life to another area? Like, that's the connective tissue, right? Tendons, ligaments are connective tissue. So are we connected to our beliefs? Are we connected to what supports us and gives us stability and flexibility and power? It allows us to stand. So how do we take a stand along with Dumai, right? The governor vessel. How do we stand up to life, right? Life throws us COVID-19. Do we retreat? Do we shrink away? I mean, again, there's our reactions, but I mean our sort of like our established response, right? I'm not talking about reactions necessarily, right? That's more nervous system, right? And sensory organs and sort of superficial conditioning that we all experience. But again, with time and like whether that be a few seconds to a few minutes to sleeping on things for a week, where do we stand on things? Do we take a stand, or do we take a position? Do we stand alone? Do we have support in our life? Do our beliefs and principles serve us as adults? That's the nice thing about adults. You get to eat whatever you want for breakfast, and you get to believe whatever you want, right? So, do they resonate, excuse me, in a harmonious way, or does our conditioning no longer resonate in a harmonious way? We're brought up by very well-meaning parents, perhaps, to believe and believe certain things, think certain things, and good stuff. However, we may reach a certain age and say, you know what? At this age in my life, at this time in my life, at this time in the world, you know what? That really no longer quite fits. As good as it was, it got me through, my first 10 years of life, 12 years of life, but now it no longer harmoniously resonates with, the truer resonance of my own Zen chi, Z-H-E-N chi, right? So, are we in harmony? Are we able to take a stand for our beliefs in a way that's harmonious for our circumstances and our vitality? And I mentioned that heel spurs sometimes are suggest the patient's trying too hard to control their environment. maybe their circumstances, or they fear change, right? Because your beliefs allow you to navigate change, right? Just as water generates wood, right? We got to move from this place of the unknown. So, you know, as we move into adulthood, that is, or at least, you know, physiologically speaking, adulthood kind of starts with puberty, right? Because that's when you can start bearing children. So that's sort of physiological adulthood, and that's when primarily our bones are set. The sacrum, which is a bunch of little bones, individual bones, actually kind of calcifies and solidifies into one unit. You know, as a baby, the fontanelle closes. So there's this sort of process of development that is also very much informed by the 8 extraordinary vessels, right? That helps us to establish a belief system, excuse me, that allows us to ponder the unknown, to experience new things that we're uncertain about, that we've never experienced before, and that lays down calcium. We lay down and establish these beliefs, right? Our ligaments become more set and established, right? Which allows us to physically and psychologically establish the foundation of our adulthood, of our unique individual nature, separate from, but immersed in our community, our culture, right? And so that's why it's sometimes necessary, as you move into the wood phase of your life, that you may need to make a drastic change. You may need to move, right? Course your chi. So, you know, maybe you were brought up in this area and you need to course your chi to Oregon or to Mexico or to, you know, Germany or to the Far East. You know, you may need to course your chi somewhere else to move that allows you to connect with your heart, right? So the heart becomes more established. So all this is a long-winded way of saying that the ankles and the feet can provide the support physiologically, psychologically, emotionally, spiritually, for us to move through life, or at least stand temporarily to bear what we must, right? Think about bearing weight, that's the Yang Ming, right? Thinking about extending ourselves out into the world, that's Tai Yang. Thinking about manipulating our reality, right? To manage, to manipulate, to change, to transform, that's Xiaoyang. Okay. All right. So I've included the anatomy. There's quite a bit about the bones and the ligaments, and let's see. Talked a little bit about the ankle joint itself. On middle of page 2, I mentioned briefly about a high ankle sprain, which is something that you, unless you're really treating athletes, gymnasts, or maybe basketball players, or especially football players seem to get this the most, high ankle sprain, and even that is not super common. So I mentioned that, and I've mentioned about the tendons and the muscles, and of course I've included a bit about the myotomes, that is what nerve root allows us to perform certain movements on page 3, right? So hip flexion is facilitated by the nerve root coming from L2, knee extension L3, dorsiflexion of the foot L4, big toe extension and the toes, that's L5, knee flexion L5S1, plantar flexion or foot eversion S1, and big toe and flexion S2, right? So I've given you also reminder to check Akabanis, check Akabanis, check Akabanis. Really important. It's not the cure-all, but it is very valuable for primary channel involvement and regulation. It's also like, you know, kind of having a conversation about this a long time ago with Heather Dorse. She also treats it when people are even having a lot of psychological or emotional imbalance, like maybe they feel torn this way or that way and they feel unstable. So she checks Akabanis for that as well. So I've also included some of the examinations, the squeeze test, right? We'll look at that, the Taylor test, tilt test for lateral ankle sprain. Sorry. The Morton's test for Morton's neuroma, Thompson test for the Achilles tendon injury, and the Windlass test for plantar fasciitis, although you don't really need to test for plantar fasciitis. There's really only one test for plantar fasciitis, and we'll go into this more. But really the only test you need is how does the patient feel as soon as they get out of bed and they take those first few steps? That's all the test you need. And then there's another range of ankle and foot tests that I've given you a link to. If any of those links don't work for you, I've tested most of them out. There was a couple I did not test out today. So if you come across any bad links, they stay up late, they drink all your booze. All right. And then I've given you, as a reminder, the sinew meridian assessments and the types of pain, just a reminder to check that out. It's really good to go through that in the assessments and diagnosis essay, the different types of pain. That's very helpful in kind of starting to narrow down your hypothesis about what this condition involves. And then it'll give you a choice of generally 1 to 3 possibilities that you can then investigate by virtue of the tongue, the pulse, and other signs and symptoms. I've given you a reminder of the climatic factors, right? Wind is like this, cold symptoms are like that, damp symptoms look like this. I've also given you a reminder on page 4, be mindful of potential deep vein thrombosis. So this is actually worse, you know, with movement, with walking. Dissipates a little bit with rest. It's worse with dorsiflexion and knee extension. So they bring their knee out and bring their foot up. That puts a lot of strain on the gastroc and soleus muscles. And if there's a deep vein thrombosis in there, that will aggravate the nerves and the muscle tissue in the area. All right, so this is really important to refer. Don't needle into the area, don't cup the area, don't gua sha the area, don't treat the area. You can treat opposite side in the moment if there's some discomfort, but this is one of these where it's not a 911, but I would say I really want you to see your doctor in the next day. Okay, because if that thrombosis sort of separates or breaks up, and a small piece of that goes up into the lungs, it will kill them.
Ooh.
Yes, this is no fooling around, seriously. All right, so I've talked about beginning of the very bottom of page 4, last 3 lines. Imbalanced postures regarding the foot and ankle include pronation, right? So pronation, the insides of the foot kind of go down like fallen arches kind of thing. That's eversion, abduction, and dorsiflexion, right? And then supination consists of inversion, adduction, and plantar flexion. I've given you a little image of from Team Doctor's blog on the top and morethanhealthy.net. I thought this was kind of cool. Really nice to see that. You know, it's on your notes. And then I thought this is neat, you know, like walking, you know, analyzing people's gait when you're at the beach. Very fun. Always good for small talk if you want to introduce yourself. Well, I notice you have a very high arch. Hello there. Has anyone ever told you how high your arches are? All right. And then on top of page 6, just a note that the stomach and bladder sinew meridians figure very heavily in foot posture. I know it may not be sort of like, what would you say, like obvious, right? But the way these 2 sinew meridians are said to be formed is they create this kind of stirrup underneath the foot, right? So here's the bottom of the foot, and they create this kind of stirrup underneath the foot, and they help to balance the arch, especially the medial arch, because of the pathways of these two meridians. So oftentimes in foot posture, we're going to be looking at the stomach and bladder sinew meridians in particular. Together, they, like I said, they form this sling or stirrup of fascia that is an extension of the peroneus longus and the tibialis anterior, the peroneus longus and the tibialis anterior muscles, which connect under the foot, pretty much at the base, close to the base of the first metatarsal. Excuse me. And these sinew meridians obviously have a big effect on the knee and the pelvic positioning, as we've discovered, right? And so the tibialis anterior supports the medial arch, and the peroneus longus, which goes down the lateral side of the leg. The tibialis anterior goes along the anterior part of the leg. So the tib anterior deals with the medial arch. The peroneus longus supports the lateral portion of the arch, right? And so I've given you a description there. So if the peroneus longus or the bladder meridian is shortened and overactive, right, and the tib anterior via the stomach sinew meridian is lengthened and inhibited, the foot will evert, leading to overpronation, right? And then the opposite would be true, leading to foot inversion, leading to supination, okay? So I know that may be a little bit hard to imagine, and it takes a little while to kind of game that out. So I've given you some images courtesy of Vinny Rehab. I think he's a physical therapist. So it talks about, so if you have an anterior pelvic tilt, and if it's a unilateral pelvic tilt, that might internally rotate one of the femurs, and then that's going to affect the tibia, right? That's going to internally rotate, and that's going to torque the foot so it pronates, right? And so it would be the opposite with a posterior pelvic tilt. The femur would externally rotate, and then that would torque out the knee, and therefore the tibia would externally rotate, and then the foot would invert or supinate, okay? Now again, I'm just throwing this out there. I don't expect you to go, oh yeah, sure, that's obvious. You know, this takes a little bit of time to game out because you're looking at the arrangement of the bones and the joints, as well as the muscles in particular. And then the muscles affect and are affected by the sinew meridians, right? So the muscles affect and are affected by the sinew meridians. And it's sort of a chicken egg conversation, you know, what came first. Generally, it'll be some kind of muscle imbalance comes first. And again, if you think about the relationship between the muscles and the sinews give us the capacity to react without thinking. The sinews give us the capacity to react and respond without thinking. So if any of you have ever seen like The Karate Kid, that's a great movie about muscle memory and how Daniel-san was trained by Mr. Miyagi to do karate. And instead of just launching him into karate exercises, he had him sand the floor, wax the cars. He had all these like antique cars in his lot. So he would like wax on, wax off. He would paint the fence, right? Go up, go down, go up, go down, right? And so he would also like do some, I can't remember what it was, like side to side, right? So, you know, he developed after like, you know, doing like days and days of these exercises where he's doing like mundane like work. Then Mr. Miyagi like practices throwing punches at him, and he's doing all of these, you know, same movements, right, without even thinking. And it's the same thing, right? You know, you're in your car, you reach for the ignition, right? You know how to apply pressure to the brake and the gas, and if so you have a clutch, right? So you have a lot of muscle memory. So if you think about the sinews as our first point of contact with the external world, with their exterior environment, right? So from an external pathogenic factor level, right, you don't want to have to think about, oh, was that a breeze? Do I need to like, you know, stimulate a shiver and a tiny sweat so I can ward the wind cold invasion off? No, I mean, you don't want to think about that. Like, who wants to think about that? I'd be dead if I had to think about that, right? So these are the things that react and respond, right? They're like border patrol with these great sensors that immediately, you know, go to where they're needed and respond in the way they're needed. So on a psychological and emotional level, this is often like our reactive nature. You know, how do you react? Like if something's coming towards your head, you know, we duck. We don't go, that baseball seems to be traveling quite fast and it's coming at a certain angle that might hit me on the forehead. Like we don't want to be thinking about that, right? Right? It's like that old joke. It's like I quickly saw something coming towards my head and then suddenly it hit me. So these also have a lot to do with how we psychologically, emotionally respond to the world, and that affects our muscles, and that affects our posture, and that affects our function, and over time that affects the flow of chi and blood through the primary meridians. So again, your sinew meridians, your conditioning, right, and the relation, the sort of unspoken kind of like what we say, your unconscious or subconscious belief systems, right? And the way you perceive the world, right? Because the Jingwell points do what? They open the sensory orifices, right? So the way you've been taught to kind of perceive your external reality determines the health and well-being and the nature of your sinew meridians, which then affects your muscles, which affects your posture, which then reinforces or conflicts with your beliefs, right? That moves the bones, moves the joints or not, right? And that affects the flow of chi, and that affects the primary meridians, and that affects our function, right? So posture, sinew meridians, reactive nature, right? This is why like becoming very self-aware about your posture, meditating to kind of like be aware of your reactions and know and sort of have this like new relationship with your reactive nature where it serves you rather than disturbs you. I don't know if that makes sense or not. So meditation, qigong, tai chi, right? Yoga, you know, all the bagua exercises, right? These help us to sort of unify and harmonize our sinews and primary meridians with our divergent meridians and our lower vessels, right? So we can respond immediately rather than react through life, right? Because there's a time to react. Something comes towards your head, you don't want to think about it. You just want to duck, right? But if you have like a harmonious relationship between your primary and your sinew meridians, which is cultivated by these, you know, practices that I just mentioned, you're not reacting when you should respond, and you're not responding when you should react, right? So when something's coming towards your head, you want to react and duck. When, you know, someone cuts you off in the highway, you don't necessarily want to respond, right? And you need the wisdom to know the difference. And the wisdom is cultivated by the kidneys. The kidneys control the bones, and I say the ligaments. Right? Okay. So anyway, there's that. Yes.
Question. Would you also say that studying or practicing yoga, tai chi, qigong, all these things help our body to understand the right way to move, the safe way to move?
Yes.
That's the muscle memory.
Yeah, the right way to stand, the right way to move, and therefore the right way to take a stand, the right way to move through life. Okay. So our posture absolutely affects our mind via its relationship to the muscles and the sinew meridians and the sensory orifices, right? Look at all these people out there right now who are completely consumed by their reactions, and they're moving through life as if what they're perceiving incorrectly is true, right? And you'll know you're in a state like that if you really start to examine your thoughts and you see a lot of contradictions. All right, page 8, common conditions. All right, So in the middle of page 8, I've given you a little bit on the grading of a sprain. Basically, 1 and 2 you can treat. 1 is a little bit easier to treat. 2's a little harder to treat. Takes a little more time and a lot more rest. Grade 3, you're not really going to treat a grade 3 sprain. That's a complete tear of the ligaments. The only thing you can really do in those situations is maybe help alleviate some of the pain and clear the heat of the inflammation and support the healing process, but you're not going to knit ligaments back together with your acupuncture. And if you figure out how to do that, please call me up and teach me how to do it. Because unless you're like strong with the force, it ain't going to happen. Unless you have a baby Yoda in your closet, that ain't going to work. All right. So generally, if there's a severe sprain, the joint, hi kitty, the joint is going to be damaged as well. There's going to be damage to the joint capsule, which means that you need compression, right? Which means it needs to be wrapped or taped. It needs to be rested. And this is one situation where ice is okay, 5-10 minutes out of every hour. In the acute phase, in the subacute phase, you can alternate it with hot and cold. Okay. You'll know you're out of the woods when the swelling goes down. So that's when the swelling dissipates. Now you're out of phase 1 or stage 1 of the trauma, right? So in stage 1, where there's swelling, possibly redness, possibly feelings of heat, and if there's no redness and if it doesn't feel like there's heat and it's still swollen and it's still pretty recent, then assume there is heat inside. Okay, just assume it's there. You'll treat as if it's there, right? So this is where they really have to rest it. They really have to rest it. This is also a time when you can use San Huang San, right? The 3 yellow powder, like the herbal ice. You can alternate that with some other liniments like Zhenggu Shui, which is good for the bones, means bone healing water. Okay, you can even make poultices out of these and leave them on overnight or just a few hours during the day, or you can have them apply the poultice at night and wrap it up and they can sleep with it on. Okay, very, very helpful. Most of the sprains that you're going to come across are going to be on the lateral side. The medial side has some tougher ligaments positioned and more dense ligaments positioned in a way that makes it much harder to sprain the medial side, which doesn't say, of course, that it doesn't happen. So these would be like strong contact sports like rugby, soccer, somebody slide tackles you, football, of course, maybe even basketball, somebody tries to stop and turn, maybe some track and field, right? Runners, of course, you might hit an uneven patch of ground. That's very common. Most common way people sprain their ankle is stepping off a curb or tripping and falling. Okay, but the deltoid ligament on the medial side is pretty tough, pretty big, and it's actually a combination of multiple ligaments all together that create kind of like this triangle, which is why they call it a delta or the deltoid ligament. And but on the outside, there's 3 main ligaments. There's the anterior talofibular. There is the posterior talofibular and the calcaneofibular ligament. All right, and these 3 ligaments are generally one of these is going to be that which is sprained. Okay. Rarely the posterior one. Not so often with that. It has to be pretty strong force, maybe like in a car accident or a bicycle accident, something like that. So more often than not, you're going to be involving the gallbladder and bladder sinews as well as primary meridians. We'll go through the ankle sprain first, and then we'll take a break. Is that cool? Is that all right? You guys hanging in there? All right. All right. So I've given you on page 8, hopefully it's the same on your notes, an assessment. So obviously pain is going to be the biggest symptom the patient reports. It's either going to be moving or standing or just bearing weight, right? Often the pain will radiate. One of the questions that I was taught to ask is, ask your patient, were you able to walk away from the injury? Any of you ever watch professional football? Okay. So, oftentimes, you see a guy able to kind of like walk off the field. He's like limping, that's probably grade 1. Grade 2, he's, limping really badly, and most likely will have, he will be assisted, like he'll have his arm draped over either a trainer or another player, and they're going to assist him walking off. And you see him, maybe putting a tiny bit of weight on it. That would be probably a grade 2. When he's like got his knee up and foot off the ground and he doesn't even want to touch his toe to the turf, that's a grade 3. That's a grade 3. That hurts like a mother. That's pretty bad. There's going to be swelling. It will most often be bruised because as the, so this is the lateral part of the ankle, as that rolls, right? And those tendons and ligaments are stretched and torn to some varying degree, not completely ruptured, but some of those fibers are torn and some of the fibers will remain, right? That is going to release some intracellular fluids in the tissue around it. It will probably also break some of the smaller blood vessels and capillaries in the area, so spilling their contents into the local area, so that you're going to have swelling. It's going to look bruised. It's going to pretty much be just around the joint. We'll get into high ankle sprains later. There's obviously going to be a lot of stiffness, decreased range of motion. It's going to hurt when you press on it. There's the talar tilt test, there's the squeeze test, there's the anterior drawer test. Obviously, the foot is probably not going to be flat on the ground. There will probably most likely be an excessive amount of pronation, most likely, because inversion will probably be very, very sore. And to varying degrees, there's going to be an ability to put weight on it. Do you want me to show you the tests now online, or do you want to look at them later?
If you can show us now, I think that's helpful.
Okay.
Yeah, I agree. I'd like to
agree.
I would agree.
We're unanimous.
All right, very good. All right, let me find my notes. This is page 8. All right. I think I already had this one up. So we got talar, squeeze, and anterior drawer. I pulled these up earlier. All right, let's do the talar test first. Let me see. Give me 1 second here.
It's in 5G.
Maybe. These crazy ads. All right. All right. Okay, share screen. All right. All right, can you all see that? Can you all see Kai? All right.
In this video, I'm going to show you how to do the talar tilt test to assess the integrity of the anterior and posterior talofibular ligament, the calcaneofibular ligament, as well as the deltoid ligaments. Hi and welcome back to Physio Tutors. According to Hertel et al. In the year 1999, the talar tilt test has a sensitivity of 50% and a specificity of 88% in the diagnosis of lateral ankle sprains. To do the test, have your patient sitting with his knee hanging off the table. In order to test the anterior talofibular ligament, bring your patient's foot into plantar flexion so that the ATFL is perpendicular to the movement that you are going to perform. Then, grab the calcaneus and perform inversion. In order to test the calcaneofibular ligament, bring your patient's foot into the anatomical position so that the ligament is perpendicular to the long axis of the talus. Then bring the foot into inversion and eversion. The eversion part of this test stresses the deltoid ligament complex on the medial side. And lastly, to put the most stress on the posterior talofibular ligament, bring the foot into maximal dorsiflexion and perform the same movement again. This test in different positions is considered positive if your patient complains about pain or if you find excessive gapping compared with the unaffected side.
Okay.
But I have a question.
Yes.
For the talar tilt test, you know, they say during the video, it's primarily used to test the lateral ankle sprain,
Yes.
but you're testing ligaments that are on the posterior part of the foot,
And the
the
medial.
medial aspect.
Yeah.
So basically, it is useful for more than just a lateral assessment of a lateral ankle sprain. Then.
It is useful, but
Okay.
it's most specific and sensitive for lateral ankle sprain. So like reliable.
Okay.
Yep. All right. So I think next we have the syndesmosis squeeze test. Oh, all right. Ads. Okay.
I will show you how to conduct the syndesmosis squeeze test in order to determine a syndesmosis sprain. Additional dorsiflexion trauma. It connects the tibia with the fibula, and it can get injured with inversion trauma or exorotational dorsiflexion trauma. The estimated incidence is 1% of all ankle sprains according to the KNGF ankle sprain guideline. According to an RCT done by DeCesar et al. In 2011, the squeeze test has a sensitivity of 30% and a specificity of 94% in the diagnosis of syndesmosis ruptures. To perform the test, have your patient in supine-lying position and squeeze the proximal fibula and tibia together. Then apply the same compression at more distal places down to the malleoli. According to Nussbaum et al. In 2001, the length of tenderness above the lateral malleoli indicates severity. So the more proximal pain is felt, the more severe the injury. Pain during these compressions may indicate syndesmosis rupture, given that a fracture, contusion, or compartment syndrome have been ruled out before. All right, guys, this was our video on the syndesmosis.
All right, so that test was for a high ankle sprain, and that's testing the ligaments that attach the tibia and the fibula. And usually, if someone has a high ankle sprain, by the time you get down to around maybe 4 to 5, maybe 6 sun proximal to the medial and lateral malleolus, that's when you're gonna that's when the patient's gonna really yelp. All right, so this is for a high ankle sprain of those ligaments between the tibia and the fibula. All right, here's the anterior drawer test.
In this video, we will take a look at the anterior drawer test for anterior talocrural joint laxity after ankle inversion trauma. Hi and welcome back to Physio Tutors. patients who experienced ankle inversion traumata can be left with talocrural joint laxity. Croy et al. From 2013 investigated the anterior draw's ability to detect laxity when compared to ultrasound imaging. They found two cutoff points for talocrural joint laxity. The first one was set at 2.3 millimeters or greater in the talofibular interval, and the second one at 3.7 millimeters or greater. Values for sensitivity and specificity were 74% and 38% for the first interval, and 83% and 40% for the second interval. Secondly, Van Dijk et al. From 1996 evaluated 160 patients within 5 days after inversion trauma and found a sensitivity of 96% and a specificity of 84% for a rupture of the anterior talofibular ligament. So it appears that the anterior drawer test has a high clinical value to detect a ligament rupture in an acute situation, but performs rather weak for chronic laxity. To conduct the test, the patient lies in supine position with the knee joint slightly flexed, and the ankle joint is held in 10 to 15 degrees of plantar flexion. Then grasp the patient's heel with the contralateral hand, while the patient's foot lies on the anterior aspect of your forearm. With the other hand, fixate the patient's tibia as close as possible to the joint line, and then draw the foot anteriorly. Alternatively, you can place the patient's foot on the table and use a plinth to put the patient's foot into 10 to 15 degrees of plantar flexion. Then fixate the foot's position, grasp the tibia with your other hand, and push the tibia posteriorly. In a positive test, you would feel increased anterior translation compared to the unaffected ankle and might be able to observe a dimple appearing on the anterolateral aspect of the talus. Miller et al. From 2016 conducted a cadaver study and found that when allowing the talocrural joint to internally rotate around the axis of the intact deltoid ligament, it was able to detect more subtle degrees of ankle instability.
Okay. That's pretty freaky, right? When you see that foot move independently. If somebody has a sprain, that's going to be painful, and you'll see it move quite a lot. So you see that in Kai's healthy ankle, there's some play there, right? There's some movement, there's some flexibility, and no pain. But in case of an ankle sprain, there's going to be a lot of play, a lot of movement, and I would practice this on some healthy patients first, so you feel what a healthy resistance is like, right? There's like this sort of tension of give, right? But also resistance. Whereas when there's a sprain, there's very little resistance. It's very free. There's a lot of play. There's less tension and a lot more pain. Like when you push down on somebody's tibia and you're holding their foot, it's very painful, very painful. All right. So obviously you're going to do the normal sinew and primary meridian tests. I don't know why I have that. That's really weird. Number 12 is just bizarre. Okay, opposite ankle ashi points that relate to painful area. That's for treatment. I don't know why I put that there. All right, so there's acute treatments and subacute treatments. So if someone has a grade 1 or 2 ankle sprain, honestly, you'd be doing them a big favor by treating them at least 2 times a week, maybe 3. And the more they rest it, the less treatment they need. The less they rest it, the more treatment they'll need. They will have to be trained how to tape it up so it can provide some compression and stability and support, right? So some kind of athletic tape or a bandage of some sort, like an ACE bandage. I don't know what they call them these days. Those are really helpful. I've given you some bullet points are basically sort of like your kitchen medicine or more allopathic style treatments, right? So rest, ice, compression, elevation, They really should get this checked out by an allopathic practitioner, whether a doctor or a nurse practitioner or what have you. And it's interesting that, you know, according to some studies, about 75% of all ankle sprains are re-injuries, right? Because they haven't been treated well. They've been over-iced, under-rested, and there's been almost nothing done to promote the healing of the tissue, both superficial tissues and internal tissues. It's basically like, well, stay off it, ice it, wrap it, you know, maybe take some glucosamine and chondroitin, and then but there's nothing else we can do. And from our standpoint, that's nonsense. I mean, there's treatments, there's herbs, right? There's a little bit of tuina, cupping, bleeding, things like that, right? To support the healing as well as to protect it from reinvasion of external pathogenic factors, because the sinew meridians have been damaged and therefore our wei qi is weak. So I would say look primarily at activating the gallbladder sinew treatment, sinew meridians. I would also consider the bladder and the stomach as well. So, you know, if it's really painful to stand on it, to bear weight, that points to yang meng's stomach. If it's hard to, you know, again, those tests are like, there's like a flexibility movement to it, right? A lot of rotation, that's gallbladder, right? Dorsiflexion, right? That's also stomach primary, plantar flexion, right? That's bladder, I might have it reversed, that's bladder kidney, right? So what I found is if there's swelling, and if it's a recent sprain, there will be, some gentle cupping and lancet bleeding over the area can really release a lot of the pressure and therefore decrease the pain. Bleeding around bladder 40, either at the point, or if you see like a lot of venous structures like spider nevi and things like that, you can bleed those. That's a sign of Luo points, Luo channel dysfunction. That can take a lot of pressure off of the joints, especially in the lower body. I think the master dung points are great. I say see page 9, but that's referring to another book. I can go over these, but there's the masterdungacupuncture.com. You can look these up. There's a number of different points that are really phenomenal for supporting ankle healing and pain. And then of course the channel balancing a la Dr. Tan, you know, using the opposite ankle, which is kind of okay, or the opposite wrist, which I think is much better, because I think the more distal, the better, right? If you're gonna look at motor points to kind of relax the muscles that might be in spasm or might try and be overcompensating, you can try the motor points or the trigger points for the peroneus longus and the peroneus brevis. They're the muscles that go along the lateral aspect of the ankle up into the calf. So doing those motor points helps to relax the fascia, relax the muscles, right? The sinews help to relax the fascia, the motor points help to relax the muscles, and that puts less strain and pull on the tendons that attach around the foot and the malleolus. All right, so those are like the main ones. And then of course, like I unfortunately repeated number 8 is a repeat of number 6. And then of course, looking at the primary, you know, tonification points, sedation points that can really support the movement and flexibility of the ankle. And this is where sprains are really good, a good opportunity to massage away from the area, right? Down, maybe down the foot towards the toes if they can take it, or up the legs, the back, the sides, the front of the leg, gentle massage, right? You can also do cupping and gua sha of the calf muscles to help keep the blood moving. You know, because sometimes when there's a sprain, the muscles can go into spasm and that aggravates the pain, right? So cupping, even gua sha of the gastrocnemius and soleus are really helpful. That will help relax those pull on the tendons, which then, you know, creates less tension on the joint. And then in the blue and green, I've given you some additional treatments to try. So basically when I'm treating, you know, if it's acute, main thing is like stage 1 injuries, clear heat, right? Reduce swelling by promoting circulation of qi and blood, and alleviate pain, right? So break blood stagnation, right? Clear heat, move stagnation, right? Especially of blood and qi, and alleviate pain. And so the sinew meridians, the primary meridian treatments, the cupping and bleeding are really good for clearing heat, moving blood stagnation, moving qi stagnation, coursing the qi through the collateral vessels, right? The luo vessels, the sinew meridians. And so, and also the just sort of the microcirculation of qi in the area. And then, you know, the master dung points, which do help circulation, but they also help alleviate pain, as well as the channel balancing points. So what I would normally do is I would probably like bleed the Jing wells first, and then, you know, open the sinew meridian with the gathering point, and then maybe a couple of points along the trajectory, and then do some gentle cupping and bleeding around the area or on the area if I can get to it, right, to alleviate that pressure, right? And you can do that while the sinew points are in, right? And then I would probably put in a couple either master dung or channel balancing points to try and help alleviate the pain. And and then maybe points for their CF or support their spirit, right? To support their mindset, you know, how bummed out are they about all this? You know, maybe it's okay, you know, they're just annoyed at themselves or maybe embarrassed about, you know, about the experience, but, you know, how's their spirit? Support their spirit, right? To help make sure that the Zen Chi is functioning well. And generally that's like a treatment. And then, you know, next treatment, again, if there's a lot of swelling still, a lot of pain, you know, I would still open up the sinew meridian. Again, you can bleed the Jingwell points again, that's fine. Maybe look closely to do like a slightly different spot, maybe a millimeter away or so. And then if there's still a lot of swelling, I might gently cup and bleed the area again. And then do some, again, massage at the end. I'll generally massage at the very end. Sorry, I didn't include that. Usually after the points are all done, you know, I'll do the massage to, you know, keep that circulation through the adjacent area going well. And then next treatment, I might do some maybe trigger motor points, mostly motor points, not a lot of trigger points, right? So again, the sinew meridians, gentle cupping and maybe bleeding if there's still a lot of swelling. Some motor points and master tongue or channel balancing points to alleviate some pain, right? You know, and then again, I'll palpate, like, do I need to do more cupping or gua sha on the calf? Like, are they still tight? And generally, you know, the patient will be able to tell you if that feels tight or not. And then I might include like some other points just to help like the more systemic aspects of what's going on, right? So maybe gallbladder 34, if I can get to it. Now, if the swelling has subsided a little bit, I'll palpate around gallbladder 40, right? So this will be like second or third visit or so, once the swelling is starting to diminish a bit, and I can kind of palpate the area without a tremendous amount of pain. Look for the deepest place you can press into gallbladder 40, right? You're looking for like the deepest well or the deepest opening of that gate. And then you want to needle deeply into gallbladder 40. And again, depth does not equal pain, right? So depth of insertion does not equal pain. So you want to needle deeply into gallbladder 40. And this can really help get a lot of qi, blood circulation going in the area. You can also do opposite side points, opposite ankle, opposite wrist points, right, to support that. And again, look at, you know, systemically, are they very qi deficient? So, you know, second, third, and continuing on treatments. Really good to do more systemic points to help support their qi, right? Gallbladder 34, supporting the nourishment of the tendons. Maybe stomach 34 to keep things moving, the G cleft of stomach. Stomach 36, right? Spleen 3, spleen 6, right? Constitutional points, CF points, very good, right? Let's see. Gallbladder 39, Once, you know, after you're sort of like out of like the first couple, 3 treatments, I might include gallbladder 39 on the same side. And I would needle that relatively obliquely and inferiorly, so pointed towards the foot. And this is really good for stimulating the circulation into the foot. It supports the blood, it supports the marrow, right? This is a really good point to support the healing process. I combine this with gallbladder 34 a lot. So this is gallbladder 39, right? So I'll get like a 1.5 to 2 inch needle, and I'll do this generally like about a 45 or more degree angle obliquely towards the foot. I go in slow, just manipulating the needle like with a kind of a tonification intention, right? This supports the marrow, supports the blood circulation, helps the gallbladder, and it's support of the tendons. So gallbladder 39 is really good. You can also do points above and below. So generally like 3rd visit or so later, I might do points above and below, like gallbladder 41, gallbladder 39. And then this is the E-stim machine I use. It's the ES130 by Ito, right? I don't know if you can see that. Okay. And then basically it just comes with like 3 sets of plugs, right? That you plug into here. And then, you know, these are the alligator clips that you attach onto the shaft, not the handle of the needle. Black goes anterior or superior. Red goes inferior or medial. You can put that on to 2 hertz, fairly strong current, you know, fairly strong pulse, as much as they can kind of stand. And I say, you know, would you be able to fall asleep with this level of like stimulation? If they say yes, then that's good, right? So points above and below can be really good. Gallbladder 39, gallbladder 41 with E-stim, really, 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 really super helpful. If there's still like a lot of stiffness, I might include Dai Mai or Yang Chow Mai. You can just palpate the opening points, whichever one calls to you, or you can read about them a little more. Dai Mai is about like sort of like allows us to twist and rotate, so it's about flexibility. It allows us to kind of deal with all the crap that we've been through in life and still go on. Yang Chow Mai is more about how we take a stand in the world, right? So maybe it's still really weak, maybe it's still hard to stand on it, so I might do the Yang Chow Mai, as well as points that help with like cold or wind, maybe damp, probably not damp, more cold and wind in the acute phase. And I've given you a list of some poultices or salves that you can put on. San Huang San, which is like a herbal ice, you want to put that on 3-4 times a day. Subacute, you can use the more cooler Dit-Dat Jiaos, the trauma liniments, right? This is all mentioned in Tooth from the Tiger's Mouth. Like these are the colder herbs, right? You can also apply this, like soak a gauze pad, bandage or a pad, apply that on there and then wrap that up and tape that. That can be left on for 3 or 4 hours during the day or overnight. And then as soon as they're able, I would say maybe after about a week or 2, they can start doing exercises to strengthen the peroneus longus and brevis. You can find these online. You can also look up McKenzie exercises or McKenzie maneuvers. That's McKenzie. And then if it's chronic, you're really going to be dealing with, you know, helping to eliminate external pathogenic factors, right? So, you know, reading through your textbook about points that move cold, dispel cold, right? Obviously, you're going to be doing more moxa, right? Jing Wells, shoestream hussy combinations, moxa on the needle, moxa needle ashi points around the area, cupping and massaging of the lower leg, motor points. If there's a lot of stiffness, it's chronic, it might be like established cold, so there's a lot of stiffness. So you want to move the blood, dispel the cold, so cupping, maybe cupping bleeding if there's a lot of blood stasis that shows up on the tongue or pulse, or sharp pains, or you can do the motor points for the peroneus muscles, the gastrocnemius, maybe the soleus, right, the tib anterior, okay? So I put a little asterisk, and that was for gallbladder 40. So the at page 10, the little asterisk, that was from number 12, where it says gallbladder 40. It's like the first line of the blue section. So something Matt Callison talked about was inserting 2 needles into gallbladder 40 really deep. And then you would take both those needles together and you would kind of twist them together, back and forth, right? So you're putting in one needle, then you're putting in another needle into gallbladder 40, about 1.5 inch needle, and then really close together, like millimeters apart. And then you would take both of those needle handles and twist them together, right? A little bit. And then you want to do that until the patient gets like a strong dachi sensation, like maybe a spreading sense of warmth or a feeling of, radiation or vibrating, right? A spreading sensation, right? And you can use the Huatos for that, the non-coated needles. Yeah.
I'm sorry, is this for number 12 that says lateral sprain, gallbladder 34,
Yeah.
39 plus 41?
Yes.
Okay, thank you.
Yes. Page 9.
Yeah.
So for lateral ankle sprain, like once the swelling has gone down a bit, right, then you can do this. Okay?
When we use this technique you just described, we're going to be basically perpendicular to the
Yes.
joint, going
Yes.
into the joint.
Yes.
Okay. Both needles.
Yes.
Okay.
Yeah, he said like perpendicular, but he said to aim it a little bit towards kidney 6. So I guess technically it's not exactly perpendicular, but it would be like a little bit tilted like down and in. Right, like aim it, he said to aim it towards kidney 6, because then you're going to avoid some of the structures underneath, like the tendons and stuff.
Okay.
All right. Yeah. I've done that a couple times. It definitely provokes kind of a law of cures experience, but it did on one person it was like quite miraculous. On the other person, I think it might have helped them a little bit more because they were able to stand on it much more quickly than I thought they would. But I get a little nervous about doing that on everybody, and I definitely want to wait till the swelling has gone down a bit. Yeah. I'm sorry, I realized I just blew past our break like a half an hour ago. So let's take a break till 10:30, and then we'll come back and we'll continue with page 11, unless there's questions about ankle sprain. Ankle sprains are not super hard to treat. Again, depending on how much pain they're in and how severe it is, I would treat them at least twice a week. More often if you can, like 3-4 times a week is ideal. Again, make sure you include a lot of the treatments in the yellow. Again, anytime there's a trauma injury, clear heat, move blood stasis and chi stasis, and relieve pain and resolve toxins. So, bleeding the sinews, treating the sinew meridians, points along the trajectory, cupping, like very gentle cupping and some bleeding if you can do that to alleviate the pressure. You can put in some masterdong or channel balancing points while you're working with that to alleviate some of the pain, and then finishing up with some gentle massage, and then liniments or poultices where you're kind of like wrapping it and adhering it to the area and then sending them off. And that can do a lot, a couple, 3 times a week can really, 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 really help. Also keeping in mind, their systemic condition, are they very chi deficient? Are they running very hot? Are they running cold? Doing points to support their chi, support their spirit. I more often than not end on those points unless somebody's in a really deep state of upset, then I might start with the spirit points and make a verbal treatment first, right? Bob Duggan said, never put a needle in to a patient until you've done a treatment first, which I thought was neat. You know, so you offer them something through word or touch, you know, and then you reinforce that with a certain point that resonates with that message for their spirit. And it can do very well, very, very well. Okay, excuse me. All right, so going into ankle tendinopathies here, this is generally more chronic situations. You know, maybe they've had some kind of injury in the past, or there's a lot of repetitive stress on their ankles. You know, obviously on the lateral side, you're dealing more with the gallbladder, the peroneals. The medial side is going to be more spleen and liver, right? You're dealing more with the tibialis posterior. The anterior, obviously, is going to be the stomach, the tib anterior. The posterior, like the Achilles, would be more the bladder.
Is he frozen?
Yeah, he's frozen.
I froze? How about now? Am I still frozen?